Learn the 2 key urine findings that can steer your management of severe hyponatremia. EndlessMedical.Academy educational case. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine, board-certified nephrologist, certified hypertension specialist, internal medicine specialist. See video description for disclosures. A 16-year-old boy with hereditary protein C deficiency is brought to the emergency department for headache, nausea, vomiting, pleuritic cough, and increasing confusion over 2 days. He has no known allergies. He lives with cats and reports intermittent weekend alcohol use. Medications are rivaroxaban and albuterol inhaler as needed, cetirizine, ibuprofen as needed, azithromycin started yesterday, and a multivitamin. Family history includes venous thromboembolism in his father and hypothyroidism in his mother. Prior records show vitamin B12 and folate levels within range, pulmonary function tests with mild reversible obstruction after cat-triggered wheeze, and a left cervical lymph node core needle biopsy 1 year ago showing reactive hyperplasia. On arrival, temperature is 36.9 degrees Celsius, pulse 115 per minute, respiratory rate 18 per minute, blood pressure 131 over 46 millimeters of mercury, and oxygen saturation 90% on room air. He is somnolent but arousable. Mucous membranes are moist, jugular venous pressure is not elevated, lungs have right basilar crackles, and there is no edema, no ascites, and no orthostatic hypotension. Chest radiography shows right lower lobe consolidation. Laboratory results show sodium 112 milliequivalents per liter, potassium 3.8 milliequivalents per liter, chloride 82 milliequivalents per liter, bicarbonate 23 milliequivalents per liter, glucose 92 milligrams per deciliter, blood urea nitrogen 4 milligrams per deciliter, creatinine 0.6 milligrams per deciliter, uric acid 2.0 milligrams per deciliter, serum osmolality 236 milliosmoles per kilogram, urine osmolality 760 milliosmoles per kilogram, urine sodium 132 milliequivalents per liter, and urine potassium 32 milliequivalents per liter. Triglycerides are 110 milligrams per deciliter, thyroid-stimulating hormone is normal, and an early morning cortisol level is normal. He has a brief generalized seizure that stops after lorazepam. After 100 milliliter bolus of 3% saline, his sodium is 114 milliequivalents per liter, and his mentation remains clouded. Given this concentrated urine syndrome of inappropriate antidiuresis phenotype, which therapy is most likely to worsen his serum sodium if used now as the sole next step? Option A, a desmopressin clamp with 3% saline if brisk aquaresis begins. Option B, 0.9% saline at 150 milliliters per hour as sole therapy. Option C, fluid restriction with oral urea after neurologic stabilization and pneumonia treatment. Option D, repeated 100 milliliter 3% saline boluses with sodium checks after each dose. The correct answer is option B, 0.9% saline at 150 milliliters per hour as sole therapy. This adolescent has true hypotonic hyponatremia with a classic syndrome of inappropriate antidiuresis phenotype. Serum osmolality 236 milliosmoles per kilogram, urine osmolality 760 milliosmoles per kilogram, urine sodium 132 milliequivalents per liter, low uric acid, normal thyroid and cortisol testing, and a likely trigger in pneumonia. He is also symptomatic with confusion and a seizure, so initial management should prioritize hypertonic saline, not slow-maintenance therapy. The choice most likely to worsen sodium as the sole next step is isotonic saline, because in concentrated urine antidiuresis, the kidney can excrete sodium and potassium in urine while retaining relatively more water. The key expert clue is the urine chemistry. Urine sodium 132 milliequivalents per liter, plus urine potassium 32 milliequivalents per liter equals 164 milliequivalents per liter, which exceeds the sodium concentration of 0.9% saline. In that setting, Isotonic saline can behave like a source of free water and make serum sodium fall further or fail to improve. Repeated 100 milliliter 3% saline boluses are appropriate for persistent severe symptoms. A desmopressin clamp with 3% saline is a recognized strategy if brisk aquaresis later threatens overcorrection. After neurologic stabilization and treatment of the pulmonary trigger, fluid restriction and oral urea are reasonable maintenance measures. The cat's prior reactive lymph node biopsy, weekend alcohol use, and mild reversible obstruction are distractors. The decisive data are the very concentrated urine, high urine sodium, and ongoing neurologic symptoms after the first hypertonic saline bolus. In summary, the correct answer is 0.9% saline as sole therapy, because in marked antidiuresis, it can paradoxically worsen hyponatremia. Teaching points. In syndrome of inappropriate antidiuresis, urine electrolytes determine whether isotonic saline will help or hurt. Severe symptomatic hyponatremia should be treated first with hypertonic saline boluses, not with routine isotonic maintenance fluid. Don't forget to like, subscribe, and share. Content created, reviewed, and approved by Lukasz Kiljanek, Doctor of Medicine. See video description for disclosures.